Hi, my name is Sophia Holloman. I will be presenting on Tinea Infections. This presentation is for Bio 4000 taught by Dr. Klobonsky. Tinea infections or ringworm are superficial fungal infections caused by dermatophytes, which are a type of pathogenic fungi. The specific dermatophyte that cause tinea infections live and feed on keratin, meaning that they infect skin, hair, and nails. The genera of fungi that cause tinea infections are Microsporum, Trichophyton, and Epidermophyton. The most common species to cause infection in humans is Trichophyton rubrum. The dermatophytes are grouped based on their natural habitats. So you have anthropophilic species, which infect humans, zoophilic species, which primarily affect animals, but can be transmitted to humans under suitable conditions, whether that be directly or indirectly. Geophilic species, which reside naturally in the ground, degrading keratin there, but can also infect humans. Tinea infections are named after the Latin word that describes the location of the infection. So you have Tinea corpus, which infects the skin, Tinea capitis infects the scalp, Tinea cruris, or jock itch, affects the groin, Tinea pedis, or athlete's foot, affects the foot, and Tinea unguium infects the nails. And here are some photos of those infections. Here are some of the specific species grouped together based on their natural habitat. So some anthropophilic species include Trichophyton rubrum, Epidermophyton flocusum, Trichophyton indigitale, and for some zoophilic species you have Microsporum canis, Trichophyton equinum, and geophilic species is Trichophyton terrestre and Macrosporum cucae. So not much is known about the virulence factors of dermatophytes, but there are speculations regarding things such as like adherence factors. It has been suggested that galactose and mannose on the skin surface may be adhesions recognized by some dermatophytes. It has also been suggested that dermatophytes may secrete proteases that help with adhesion. We do know, however, that dermatophytes have the ability to degrade keratin. This is one of the most important virulence factors that the fungi have. They can do this via enzymes or toxins. The main enzyme involved in invasion of stratum corneum are keratinolytic proteases, which break down keratin. However, these enzymes would not be able to digest keratin if the disulfide bridges were not previously reduced. The compound sulfite is responsible for breaking down these bonds so that the proteases can act. Additionally, scientists have studied pathogenic mechanisms of other fungi and used that knowledge to predict virulence factors for dermatophytes. One such factor that has been predicted is xanthomegnin, which is a mutagenic mycotoxin. This toxin has been found in the nails and skin of infected patients, but not in uninfected patients. Melanin has also been predicted to somehow be involved in the pathogenesis of dermatophyte infections. But again, all of these factors may vary based on which specific species is being studied. So as for the pathogenesis of tinea, it of course begins with transmission, whether that be directly or indirectly. From there, dermatophytes adhere to the surface of keratinized tissue by the germination of Anthroconidium, which are fungal spores, the hyphae, which are branching filaments of the fungi, think like tree roots, then penetrate the stratum corneum. The dermatophytes then begin producing keratinolytic proteases that break down the keratin. The scaly skin that is associated with tinea infections are the result of keratin being broken down. The infection spreads deeper into the skin, infecting hair follicles, which cause the hair shaft to become brittle and break, which leads to hair loss, which is also called alopecia. There's a local inflammatory response once the body begins recognizing dermatophyte antigens. This brings about classic inflammatory symptoms like redness, swelling, itchiness, and heat. The infection progresses centrifugally, causing the ringed appearance of the lesion. So tinea typically presents with a rash that is itchy and red. These lesions are circular or round with distinct marginations and a scaly edge. As the lesions grow out, they leave a central clearing that has some scaling. This appears as the ring appearance that I talked about in the previous slide. Complications are usually uncommon in tinea infections, but of course they're still possible, especially in people who are immunocompromised. These complications include Mahoki granulomas, excuse me, cellulitis, and hair loss. Mahoki granulomas occur when the dermatophyte infection invades a hair follicle and reaches the dermis or subcutaneous tissue. These appear as red nodules or papules, which can progress into abscesses. So tinea is transmitted through direct contact with infected animals or people, or by indirect contact with contaminated fomites, which include like clothes, bedding, towels, and that sort of thing. It can also be transmitted via damp environments like pools, locker rooms, and shower stalls, as the fungi thrives in warm, moist environments. Tinea is typically diagnosed just through physical presentation. However, sometimes physical examinations are not enough to diagnose tinea. In these cases, healthcare providers they have several options for diagnostic testing. One option is a histopathological examination of skin scrapings or nail clippings under or using a potassium hydroxide preparation. This allows the person performing the examination to see the septate and branching hyphae under a microscope. Another option is to do fungal cultures, which are more specific than the histopathological examinations, but take a significantly longer time. So, this takes a few weeks. PCR tests are another option for diagnosis, as well as a Woods lamp test. A Woods lamp test consists of viewing the infected area under ultraviolet light. If the area is infected with dermatophytes, it will glow under the light. However, this is only effective for tinea caused by Microsporum canis and Microsporum aldoni. Tinea infections are treated with topical or oral antifungal medications. Typically, topical antifungals are used first. These therapies are used once or twice a day for several weeks. Some of these medications include clotrimazole, ketoconazole, micoconazole, naphthene, and terbinafine. And some of these can be bought over the counter at any drugstore like Walmart or anything. So you don't even have to necessarily go to the doctor for these type infections. But in some cases where the infection is widespread or not completely resolved by topical treatment, oral antifungals are prescribed. These are taken for several weeks as well. These medications include terbinafine, itraconazole, and fluconazole. All right, here are my citations. This concludes my PowerPoint. Thank you for listening.